So I'll be giving a talk on from data to action, linking disasters and health information system data to inform policy. So the objectives of my presentation is to present descriptive studies of two health information systems. One, namely SPEED, Surveillance in Extreme Emergencies and Disasters, which is a DOH database. It's a system done by DOH and which was developed in collaboration with WHO, and EHATID. It's a Ateneo EMR, Electronic Medical Records, that is being used in 450 municipalities around the country. Okay, and it's a routine health information system. So there are two different types of systems. I want to describe how existing databases and routine data collection can inform health leaders in making decisions in disasters and also for climate change. And I want to identify resources needed to use data for policy actions. So for one, I'll describe syndromic surveillance. So the purpose of it is to detect outbreaks in real time and to provide situational awareness during disasters and emergencies. So syndromic surveillance usually is indicator-based, meaning you use syndromes, use medication sales, absenteeism in work and in school, or patient chief complaints in hospitals. It's usually automated or used based on an electronic medical record, and you use algorithms to look at trends, and it's usually near time or real time. So SPEED, the background of it, surveillance in post-extreme emergencies and disasters. You have 21 syndromes that it records. It's only activated during disasters, so in normal times it's not being used. It's used in parallel with regular reporting systems such as PIDSAR. There are two types of cases, one used by health workers, one used by doctors or medical professionals. So for health workers in evacuation centers, barangay health centers, or RHUs, they use the syndrome, so there's a case definition for that. And for medical doctors or nurses in hospitals, you can use the initial diagnosis or the description. So these are the 21 syndromes. I broke them down into three types. So you have communicable diseases, so you have acute respiratory infection, suspected measles, acute hemorrhagic fever, which is sort of like dengue, suspected meningitis, suspected leptospirosis, fever with other symptoms. You have diarrhea there, skin disease, animal bites, conjunctivitis, tetanus, and also acute flaccid paralysis, which is an indicator also for polio. So it's useful now with our measles and our polio outbreaks. For injuries, you have open wounds, bruises, and burns as one syndrome, and then fractures. For non-communicable diseases, you have high blood pressure, DM, diabetes, asthma, and acute malnutrition. So my studies, I have actually three publications based on SPEED. So existing databases are very useful. Make use of them if you have access to them. I was lucky that I worked for HEMB before I went to my master's studies and my doctorate studies. So I was able to access the data. So you have to be a little bit political and try to be friends with the agencies who actually have the data. So I will present first a study where I looked at three disasters, a flood, so this is the Luzon flood, Bohol earthquake, and Typhoon Haiyan in 2013. So the way I described it, I used time series analysis, I used rates based on local population data, the denominators based on the health facility type of the report. I used Poisson regression because of the count variables that we use. The units I used per 10,000 population because that's how emergency health kits are allocated per 10,000 population. I used graphical representations using scatter plots, spline, and multivariable fractional polynomials. So I broke it down. There were different types of health facilities used in SPEED. I combined the smaller ones like village health centers, mobile clinics, and foreign medical clinics to village health centers. Hospitals, I combined local and foreign hospitals. And then I use the different populations. So for community health centers, I use the municipality. For evacuation centers and village health centers, I use the barangay health center, barangay population. So what was nice to see, I demarcated between before 2 months and after 2 months based on my scatter plot. It showed that before 2 months, you had most of the consultations during that time. So, and then when you average it all, you can see that for the flood and the earthquake and typhoon, the difference between before 2 months and after 2 months was drastic if you compare the communicable diseases. So, and it would show also the magnitude of the disaster. For example, we can expect Typhoon Haiyan to have the highest number of consults, which you actually had, followed by the earthquake and the flood. But after 2 months, everything normalized. So it was funny that they had almost the same rates for all the disasters, 14 for communicable diseases. For the top 6 syndromes that I saw, so acute respiratory infections were the highest, followed by open wounds, high blood pressure, skin disease, fever, and acute watery diarrhea. So the problems that you see in disasters are very primary care, very basic. You don't even see a lot of fractures, even for Typhoon Haiyan. So you'll expect wounds, burns, cuts, high blood pressure during these disasters. So overall, the results show the country's morbidity profile. What's common in normal times is what's seen in disasters as well. So within 2 months, you can see the severity and the magnitude of the different disasters. And then after 2 months, rates dropped. And the most common syndromes can be addressed by measures such as shelter, water, sanitation, hygiene, nutrition, and common health services. So everything that Dr. Sumili said, we saw in our descriptive study. So in Typhoon Haiyan, next slide, you can see that this is a time series analysis of that using scatter plots and spline. Acute respiratory infections really had the most number of consults compared to even wounds and hypertension. So the rates of ARI are very much common. You'll see that. So those who are responding to disasters, you can expect a lot of ubutsipon. And here is a breakdown of the major syndromes that you see. Acute respiratory infections are the most common. So communicable diseases had the highest rates. Children were the most vulnerable. So the second square, you can see the difference between below 5 and above 5 population. So children really have the higher rates compared to those below 5 have higher rates. Community health centers consistently had the highest rates among the 4 health facilities, and it's a predominance of primary care conditions. So I was also able to access data for the Zamboanga armed conflict. And this is quite different from what you'd see in the natural disasters or the natural hazards. So compared to the previous 3 disasters, Zamboanga armed conflict had more consults in evacuation centers and village health centers. It just shows that it's very compact, the Zamboanga armed conflict. So most of the care was given in evacuation centers. This picture shows actually the difference between the 2 health facilities that had the highest rate. So it's the one with the higher peak is actually the village health center, but evacuation centers had consistently higher rates compared to those from village health centers. And top syndromes are very similar also to other disasters: acute respiratory infections, fever, watery diarrhea, skin disease, and hypertension. So again, more basic health facilities were needed in disasters. So here in the Zamboanga armed conflict, it's still evacuation centers and village health centers. In the previous disasters, it was community health centers. So hospitals actually they don't have higher relative rates compared to the other 3 primary care centers. So primary care is very important. So you can expect to have common infections and hypertensions as your highest conditions seen in these centers. And we can attribute the tendency for having hypertension as prominent because of the prevalence of hypertension in our country. So it just shows that you need to prepare for maintenance medications during disasters for hypertension and also diabetes. So in all these disasters, we see that speed can actually assist decision makers. This didn't really show the real-time need. This shows the preparedness needs of the different health facilities that you'd expect to cater towards the population. So the data from speed, rather than being used for real-time reporting, you can use it to prepare for the next disaster. And since Typhoon Haiyan had it's like the benchmark for preparedness, you can use the rates for Typhoon Haiyan to prepare for the next one. So expect the number of consults in the next disaster. You can use the Typhoon Haiyan rates. And then to overcome limitations in terms of the data that you have in speed, you have to correlate it with also data from other health information systems. So that's the limitation of this study. It's just focusing on speed, and we weren't able to access other health information systems. So another portion of my study is to look at the use of routine health information systems. So previously we used SPEED, which is really for disasters. This one, I wanted to study it because you can use it for climate change or modeling data later on. So I wanted to see if you could use the data that they have in local EMRs to use for climate change modeling. However, because I only had one municipality, I'll just give you a description of what I saw. So EHATID is usually used by the MHOs or the local chief executive. They use ICD-10 counts, and my pilot site was in San Jose de Buenavista in Antique. So again, you can see that hypertension and acute respiratory infections had the highest rates. So it's really common. But what we didn't see in SPEED was urinary tract infection because it's not there. Okay, so fever with other symptoms, you could attribute that to a UTI, but maybe they can add it in SPEED since SPEED is actually modifiable. So compared to other disasters, the rates are actually very low. So it just shows even compared to disaster times in recovery, the rates for those times are very abnormal compared to normal times. So this data can actually be used for the baseline. So how can we use these health information systems to impact governance in health? So basically, SPEED can be used to aid in disaster preparedness. So you get data from response and use it for disaster preparedness. And that's one way of using health information systems. You can do a retrospective study, which I did. And then if you're using the health system building blocks framework, health information systems lead towards better governance in emergencies and disasters, which can aid into better allocation of medicines, better number of health professionals that you see in disasters, how much funding do you need, what service delivery you actually need in disasters. And this is to improve health during emergencies. But governance is also needed to maintain these health information systems. So so my data is only 2013. It hasn't been used a lot the following years. So you need governance to sustain it. So they weren't able to retrain, they weren't able to reuse the system, or they're using another system. The Japanese now have a J-Speed that they're selling again to the Philippines. So, I mean, we already started it, and people are replicating it, but we don't use it. So, we need better governance in the use of health information systems. Okay, so some pearls and pitfalls in dealing with databases and working with data that's not yours. So access is important. So I wouldn't be able to do this study without access. So you have to build networks, build partnerships, collaborations. You have to understand data sets are imperfect. You just have to be transparent about it. Learn about e-health because that's where it's going to be. You can use actually PhilHealth data also if you want to model and you want to see how health information is used or what you can actually get out of it. And then we also, as researchers, researchers, we have to be sensitive to the agencies that we work with. We have to treat this as a shared exercise. So you have to partner with them. So my co-author is Dr. Ronald Lau for HEMD. We work together really well in publishing, in asking me, clarifying things regarding how speed was used. So it was a big help. Acknowledgement should be given. Make sure that you treat your partners with respect. Communication is also important. And treat it as a first engagement and as a proof of concept for future collaborations. Because if you do well in your first engagement with these agencies, you can build trust, you can ask more data, you can do more studies, and both of you benefit. So these are the publications that I was able to study with speed alone. So actually there's another one. So it's just one database, and I was able to publish 4. And I think we actually have to revisit a lot of these health information systems that are already there. And since we are all researchers, maybe we can really collaborate with our government groups or agencies which have these data to help them improve their policies. Because I'm sure since my co-author is a policymaker, then hopefully it can be used in what they do in HEMD. Okay, so that's it. Thank you. If you have any questions, you can email me in any of the emails.